Yeah. And just recording the lecture, just to keep it to my records, and maybe posting it on my YouTube page. It's not active, just like educational material every now and then. Okay, so let's see. So I didn't put any title on this. There you go. So it's going to be like a series of cases that have a central theme that's connected together. So we'll try to go through them and see what's going on. So this is a patient that was presented by one of our residents in Johns Hopkins during my fellowship training. A 3-year-old girl with a history of anisotropic amblyopia with high myopia of one eye, right eye. She used to wear contact lenses since she was 6 months old. But due to the fact that poor compliance with contact lens and patching therapy, she was switched to glasses. So she's wearing -9 contact lens in the past with patching left eye 3 hours a day. She has intermittent exotropia, mainly of the right eye. She's otherwise healthy. This is her vision check. I'm not sure how they can do that in 2 years old, but this is what was reported in the system. So her vision was decent, but you can tell her glasses are pretty asymmetric. She's like -9, 10 in the right eye and just plus quarters in the left. And then here posterior segment is normal. This is her strabismus exam. She has pretty comitant exotropia, 45 prism diopters everywhere. And you can tell from our interpretation of strabismus, there is no restriction of eye movement, and this is straightforward entire exotropia or sensory exotropia of the right eye. So she underwent uneventful bilateral lateral recession of 9 millimeters, and she came for the first week post-op, and there was residual exotropia of 20 prism diopters with no much in concomitance between 2016, but there was a surprise of esotropia in the extreme left gaze. So the orthoptist came to Dr. David Guyton and tell him what's going on here. This is esotropia, but when we look at the motility function, there is no restriction of the eye movement, just like trace limitation when we do a big recession of the lateral muscle. For the first few weeks after surgery, you see like trace or -half restriction or so. So what do you think? What is causing this concomitant results after the surgery? What would be the first thing that comes to your mind? You may think about slipped muscle, right? We weaken lateral muscle, so it can be slipped, but we do not expect to see full movement, right? We expect to see limitation of abduction, and the eye will be esotrophic even in primary gaze. So it is not slipped because the movement is full. It could be sixth nerve palsy, but what can cause it after surgery? And again, she has full movement. Okay. No idea? All right. So remember, the patient is wearing this thick glasses in the right eye. And what we saw initially as the concomitant esotropia in the left eye was due to the fact that she's looking through the base of the prismatic effect induced by her thick glasses, right? So it is the prismatic effect of the right eye. So let's dive a little bit more into the topic of prisms today. Okay. I think I can take off my mask, right? I mean, other 6 weeks from guys. Okay. So prism basically is reflecting surfaces that divert the light beam toward the base. Okay, and it's measured in the unit of prism diopters. So it's mistakenly sometimes like diopters. It is prism diopters. It's different from the word diopter, which you use to measure the strength of lenses, right? So one prism diopter is a prism that diverts the light beam 1 centimeter when the object is located a meter away from the prism. Okay, so this is an example of an image formed, and then when you introduce the prism in the way, the light rays will bend toward the base. Okay, so light bends toward the base. Think about blink to light. When you check kids, BTL, base, blink to light, or light bend toward the base. Just like you do some mnemonics so you can understand first and then memorize it. Okay. Then there will be a real image that is formed by the displacements of the convergence of the lights here that will also divert toward the base. But in practical life, in the clinical life, this is not important concept, because what is important more is that the virtual image that is formed by the continuity of the rays will be bending toward the apex. Okay, so just as you're checking VA visual acuity, virtual image go to the apex, VA. Okay, so ignore the concept of the real image because it's not very applicable in practical life. It is mainly like for testing purposes. So just keep two concepts here. The lights will bend toward the base and the virtual image will go to the apex. Okay, let's reflect more into this concept because I did not understand it first until I make this animation. So we are looking at this object. The lights are shining from the object toward the eye. Then a prism hit in the place. It will bend the lights toward the base, as we mentioned, right? So the eye will miss the shape, but when I look into the rays, the eye will basically see the virtual image made from the connection of the diverging rays from the prism. Okay, so just like you look at the mirror, you do not see the actual real image. You are seeing the image that's formed by the reflected rays from the mirror, right? So same thing happened here. So virtual image is basically the image that we see that is formed from the virtual connection of the rays that are refracted or reflected from the object, whereas the real image is the image that's formed by the actual refracted rays. So when you have convex lens, for example, when the light hit the lens, it will converge and form a real image as the one that we see with indirect ophthalmoscope, right? But with the virtual image, we are seeing an erect image that is formed by the rays that are virtually connected from the diverging light here. Okay, so let's go back a little bit. So here's the object with diverged lights. We see it. Prism comes the way. They will bend to the base, and we connect the dots. And what we see actually is the image that is displaced toward the apex. Just I'm going to give you some like hands-on. So no one will just look at me, you know, with prism. You will see me shifting. So put it close to your eye. So close one eye. So my image shifts this way because you're holding the apex this direction. And then we're going to prism the more of the deviation. Or base down if you want to hold it. So I jump stop, right? Okay, cool. Got it right here? Any questions so far? So again, the lights bend to the base and the image bent to the apex. The virtual image bent to the apex. That's why we see the image moves up. So again, a unit of prism diameter is equal to the amount of 1 centimeter bent of the image of the object that is located a meter away from the prism. One of the cool pictures that David Gatton used to, he had like a nice optics lab in his clinic. So he has like 1 meter, you know, the old wooden ruler taped to the edge of the table. And he has a prism, so the rested here and the prism is put here within a meter from the ruler. And you can see that if you put 45 prism diameter, you're going to see number 45 in the ruler in the view. So basically just, you know, 1 centimeter per 1 meter. And you can also apply that in our Lancaster with green test, you know, the plot we have in some clinics. So when it's viewed from 1 meter away, each dot is 15 centimeters, so it represents 15 prism diameters. Okay. So there is interchangeable concept of using angles with the prisms. So we know each degree of deviation of the light is equivalent to 2 prism diameters. Okay, but this relationship is true until we reach 45 degrees. So this is not a linear relationship, it is like a trigonometric relationship. So I always have this concept of, is it 1 angle 2 diopters or 1 diopter 2 angles? I get confused, so then I put this number for me just to keep myself reminded. So 1 degree has 1d to prism dot of PD. So PD is 2 and D is 1. So 1 degree is equal to 2 prism dot. Just a way of remembering everything. So yeah, as we said, so the angle of deviation in degrees is multiplied by 2 to give you the prism data until we reach 45. After that, it becomes exponential. So when you have 90 90 degrees of deviation of the light, there will be infinity prisms for that. Okay, so and again, if it's 45 degrees of deviation, you can imagine a patient with 45 degrees of exotropia. This is around 100 prism diopters. Okay, the application of this basically is the Hirschberg test. So with each deviation of the light, 1 millimeter equal to 7 degrees. This is different rule. So 1 millimeter deviation of the light with Hirschberg equal to 7 degrees. And you know that 7 degrees multiplied by 2 equal around 15 prism diopters. So when you have a patient who has displacement of the light reflex by 1 millimeter, this is esotropia of 15 prism diopters. Okay? And if you have a patient whose light reflex is displaced to the limbus, this is 1, 2, 3, 4, 5, 6, because the corneal diameter is 12, so half of it is 6. So 6 multiplied by 7 multiplied by 2 equal to 90 prism diopters, roughly. Okay? So again, each millimeter is 15 prism diopters. The use of term angle is not that frequent in strabismus measurements. You see some articles speak about that. It has some application when we deal with the head tilt and posture, stuff like that, to see how many prisms you need to hold to correct for this, head change in angles. But in practical life, think about Hirschberg and Krimsky test. Each millimeter displacement equal to 15 prism diopters. Okay, so what happens if we hold the prism in front of a normal focusing eye? So this is the right eye, and left eye of patient looking at this eye. Then we bring the prism in front of the right eye. Then the light will bend toward the base, and that will fell on a new point in the retina that is located temporally from the fovea, right? What happens is that this point will see the image, the virtual image, remember, will be shifted toward the apex. Okay? So this new point will see a virtual apple that's displaced to the left, toward the apex. But then the eye cannot recognize this double vision, cannot tolerate this double vision because it's normal eye. So what happens, the eye will adducts. So the medial retina will contract to bring the fovea point F back in control, and that will be aligned here, and the patient maintains binocular single vision. So by holding the prism base out, I have induced temporal displacement of the image that induced convergence, right? So I want to induce convergence on you. I want to measure your convergence amplitude. I want to see how long you can handle prisms, how much prism you can handle before you are losing this convergence capacity. I hold my prism's base out. So my apex will point toward your nose to check your convergence. Okay? So the real image, as we saw, will bend to the base. Corrective eye movement will go to the apex. Okay? So that helps us in measuring convergence amplitude. So when we want to measure convergence amplitude with a patient with suspected convergence insufficiency, we hold the prism bar base out. And we'll increase it one by one, holding like an fixation target, and see if the patient can see single until you can break this down into double vision. So again, base out to measure convergence, base in to measure divergence amplitude. Okay? And this is the normal values for convergence amplitude. I memorize it in the fact that we know that we have stronger convergence than divergence. And convergence is stronger at near than distance, right? So the maximum convergence normally is around 35 to 45 at near. Half of that number is our normal convergence amplitude at distance, roughly. And the same number that we have for distance is equal to the divergence amplitude at near, because at near we do diverge, but not that much. At distance, we do diverge much less, and we have half of that. So again, start with the maximum of the prism bar, around 45, 35 to 45. Half of that 16, and then 16 at divergence, and go down to 8 for distance. Okay? So again, measuring amplitude by holding the apex toward the desired movement. So we measure the convergence, we put the prism base out. We measure divergence, we put the prism base in. Clear? Okay. Another application for this concept is when we do induced trophy test, when you check visual acuity for kiddos who cannot interact visually with classical optotypes, and we want to check their visual behavior by checking if they have CSM, central study maintained. We use the induced trophy test. Or we also use it in the monofixation syndrome patients who have no strabismus or have microtropias by doing the 4 prism diopter test for microtrophy. And the concept for both is like this. Basically, you hold the prism base down and induce trophy test. Typically, we hold around 16 to 18 prism diopter to induce a movement that we can appreciate. So what happens here is the lights come and hit the prism. It will bend toward the base, right? So the real image will form. So the fovea will go below the fovea. So the eye will move downward to keep the fovea in control. So since the eye is going to rotate, the fovea will go downward, the cornea will go upward. So we're going to induce hypertropia. As we mentioned before, the apex will be pointing toward the deviation, to the direction of the eye movement. So with convergence, we did base out. For hypertropia, we did base down. Okay, so we induced hyperdeviation of the left eye. And because of hearing low, there will be equal and simultaneous innervation to the elevators of the other eye. So the right eye will also go up. Indicating that this eye did recognize the image shift. And the fixation here was central, steady, and maintained. That induced a vertical movement of the other eye. If you switch the prism, for example, and this eye is ortho but has an asymptotic amblyopia, the image shift will fall in the suppression scotoma of the right eye, and the eye will not recognize the image shift, so it will not move. So there will be no induced movement here. So this is going to be CSM, this is going to be CSUM, and maintain. Okay. So this is an example. You put the prism, the light bent, but the eye did not recognize it. So no movement here, no movement there. So this is CSUM. Same concept with the 4 prism depth of test. We hold the 4 prism base out at this point to see if the small suppression scotoma is persist. That will help do so. Now we get the concept of holding prisms in front of the normal eyes and how we can measure the divergence amplitude, whether it is convergence, divergence, vertical divergence as well. Okay. Now what happened when we use prisms for strabismic eyes? So this patient, for example, normally there is let's go back here. So we have the foveas in both eyes focusing at the apple. At the same time, we have a left visual field connected to the nasal retina of the left and temporal retina to the right. Nasal, temporal, right? And the right field is connected to the nasal retina of the right eye and temporal retina of the left eye. Right? So let's say this patient develops 6-nerve palsy of the right eye. So there will be esotropia. Now, these points will be re-registered, right? So the fovea is here, looking at the apple. What's going to happen next with esotropia, the nasal point will be looking at the apple at this point, right? And the fovea will be looking at the cup. The fovea will be looking at the cup, and the nasal retina will be looking at the apple. Okay? So here, the fovea will be looking at the cup. Again, the fovea is the dominant point in the retina, right? The central fixation. So the peripheral points are there, but our 20/20 vision is in the fovea. So the fovea initially will be looking at the cup, while the fovea in the normal eye is looking at the apple. So the first thing will happen, the patient will come up with image confusion when the brain tried to combine 2 different images, 2 different objects. Okay? So the apple will try to compete with the cup in the brain. And that may be misinterpreted by patients as double vision, but this is actual image confusion. Attempting to seeing 2 images of 2 different objects. Okay? Now with time, the brain recognized this is not sustainable. We cannot do that for a while. So then the new fovea, the pseudofovea, the nasal point that is originally directed to see the ice cream, sorry. Yeah. Was initially designed to see the ice cream in the temporal field, right? Will become our new fovea. Okay? So we're going to see the apple instead. But in the brain, this is nasal retina. So it is designed to see things in the temporal field. That's why after confusion, the brain will see two apples, because the new nasal retina will see the apple, and the actual fovea will see the apple. So again, two apples, but then the apple will be seen in the temporal field. And that's why the patient with esotropia will have uncrossed diplopia. I never understood that until I did this animation to get it done. Okay, let's go back a little bit to get it. I think there is confusion here. Okay. So again, F, phobia is look at the apple. Right temporal, left nasal looking at the cup. Right nasal, left temple looking at the ice cream. The patient developed esotropia, again, reduced at the points. So the phobia will be looking at the cup, while the original phobia is looking at the apple. So the brain tried to combine two different images of two different objects, and this is lead to image confusion. The cup over the apple. Okay. With time, our new phobia will take control and try to see the apple, while the left eye is facing at the apple. So we're going to see two, because this nasal retina in the right eye is connected to the brain to seeing objects in the temporal field. That's why the new image will be double vision, two apples, and the right eye sees image on the right. That's why it is uncrossed diplopia. Got it? Any questions? Yes.
The question I have is, what determines like what eye is the dominant? I mean, is this, you know, like we're obviously seeing the apple with the left eye, and that's what we end up seeing as double vision. Yeah. But the phobia of the right eye in this animation is seeing the cup, and that's on the nasal retina of the left eye.
Say it again. So left eye.
So right now, in the right eye, the phobia, the true phobia is looking towards the cup.
Yes.
I guess how come is it just because it depends on which eye is dominant, which image gets, you know, interpreted as
dominant eye plays a role, but we're talking about different mechanism of diplopia. So kids cannot see double vision. We're talking about adults who develop acute, you know, strabismus after 6.5 palsy or so. Again, what determined here is that, you know, we are trying to maintain central fixation, so you cannot again look at the apple and cup at the same time. So we are focusing on the cup and trying to use your deviated eye, but the new point is designed that you see the apple temporally. That's what you see two different images.
Right. I guess the deviated eye though, and its true phobia is seeing the cup. I guess is there a reason why we don't see two cups instead of two apples? That makes sense.
The true phobia sees the apple now, but with the deviation, the new phobia will look at the apple.
I guess, and this is probably like doesn't really bear with anything, but I guess in the right eye with it deviated, it's looking towards the cup. And I guess my question is there a reason we don't see, instead of seeing two apples after a while, why we don't see two cups?
You may see two of everything,
Okay.
but just the concept of focusing on the central fixation to elimination.
No, I mean, yeah, I think it doesn't really.
Yeah, so you're going to see a double of everything, but I'm just explaining how the nasal retina will take control in seeing the central fixation target that is perceived in the brain to be temporal, and that's why we have uncrossed diplopia.
Gotcha.
Right? So the opposite concept will be when you have exotropia. So yeah, we hold the prism here. Okay, so we want to fix this patient. We hold the prism base out, so the apex pointing toward the deviation, right? And we redirect everything. So we can reconnect the dots. So when we put the prism, everything will bend to where it should be. So we're gonna follow the whole thing. So we are connecting all the dots again. So the fovea will be looking at the apple, and the nasal retina will look at the ice cream, and the temple will look at the cup. So we're gonna end up with seeing single vision. This is binocular single vision. Okay. Let's give another example for induced exotropia. So again, the same example we have here, but the patient developed slipped medial rectus muscle or whatever pathology within the palsy that caused exotropia. And exotropia here, as we said originally, the fovea is looking at the ice cream now, while the good fovea is looking at the apple. So you're going to see two different images of two different objects of image confusion of trying to fuse apple to an ice cream. Okay? But then with time, our new fovea will try to look at the apple, but this is registered to be responsible for the nasal visual field. So we're going to see two apples, but the new apple will be seen in the right eye in the left gaze. And this is uncrossed diplopia. This is crossed diplopia, sorry. The right eye will see the image to the left because the temporal retina now becomes the new fovea, right? Which is designed in the brain to see images in the left field, in the nasal field. So that's why we have crossed diplopia when we have induced exotropia. Okay, then we have the prism base in the same concept. We're going to redirect all the light beams. So our new fovea now will be looking at the apple. So we have single vision. Here, I know it's confusing, but I think this animation make it slightly understandable. Okay, in real life we test this by Worth dot test, right? And with Maddox with neuroophthalmology. So basically, we know that exotropia lead to crossed diplopia, and the reason why was just mentioned. Okay, so just think about exotropia, crossed diplopia. Okay, esotropia will lead to uncrossed diplopia, or ET lead to uncrossed, like European Union, EU. Okay. So cross diplopia with Worth dot test, as we know that we put the red on the right, RR, right? So when there is cross diplopia, the patient will see the red to the left and the green to the right. Okay. Whenever we have the uncrossed diplopia, the patient will see the red to the right and the green to the left. Okay. So application of prisms and strabismus is plenty. We use them for measurement. We use the Prism test and Prism cover test with simultaneous Prism cover test, but the concept is the same, that the apex always pointing toward the eye deviation. So check esotropia with base out, check the hypertrophy with base down, stuff like that. Okay. So although we guide ourselves at the apex point to deviation, but we always mention the prism based on the base, not on the apex. So you don't write in your interpretation, I hold 4 prism diopter apex in. No, you have to mention base out. Okay. We use it as a management to relieve diplopia, to correct abnormal head postures, to assess the likelihood of diplopia after strabismus surgery. This is called Prism adaptation test. So we can simulate the surgical outcome if we keep the patient ortho, holding the prism on. And it's used in vision therapy sometimes with certain types of convergent insufficiency. Okay. So this is an interesting talk about how to hold the prisms when you measure. Keep me updated with the time. I lost track. What time is it? Oh, 8. Okay. Okay, so the position of minimum deviation basically is when the angle of incidence is equal to the angle of emergence. And this depends on how you hold the prism and how the light indents the surface and reflect and exits from the prism. Okay, so angle of incidence equal to the angle of emergence. This is the position of minimum deviation, and then we have apprentice position. Apprentice position means that when the prism, when the light hits one of the surfaces of the prism, 90 degrees, so there will be no bend. The light will exit the first surface, straight line, and will bend only in the exit surface of the prism. Okay, so this is called the apprentice position. So as you can imagine, the position of minimum deviation has less deviation that have taken place in the prisms. It is used for calibration of prism bars and the loose prism that you have in your hands. Okay, for plastic prisms. The apprentice position prisms are the prisms that are typically designed for maximum deviation, and they are calibrated on the glass-based prism that we have in trial frames in all trial sets. Okay. So again, think about Apprentice with the glass GP, like general practitioner, whatever we memorize it. So again, the glass goes with the Apprentice, the plastic goes with minimum deviation. Okay, how is that different? What is the significance of this concept in our practical use, clinical use? So let's say we have a patient. So this is 3 different ways of holding prisms in front of the patient eye. This is how the Apprentice position is held. So you put the prism surface parallel, or 90 degrees to the axis, to the visual axis of the deviated eye. Don't forget about it. So yeah, basically, you follow the deviated eye, this exotropic eye, and try to hold the prism. The back of the prism will be 90 degrees to the axis of sight. Okay, where in the minimum angle of deviation, you try to make the angle parallel, equal at this and divergence. Okay, so let's say we have a patient who has 40 prism diopters. Okay, this is a very challenging position to try to simulate in real life. So the position that mimics this position is what's called the frontal plane position. So by which we hold the prism, the back of the prism, parallel to the frontal plane of the patient. So when you want to check strabismus, you hold the back of the prism parallel to the frontal plane. So if the eye is out, you keep it in the frontal plane. You don't hold it perpendicular to the eyeball. Okay? Because again, we mentioned that the classic prisms that we have, the loose and the prism bar, are calibrated in the minimum angle, minimum deviation position. But the loose prisms are calibrated in the Apprentice position. Okay? So again, if we have a 40 prism diopter exotropic patient, and we use the prism bars in the frontal plane position, the actual magnitude is 41, which is again negligible difference in clinical life. But if you hold the prism mistakenly, where the back of the prism is perpendicular to the sides of the patient and the Apprentice position, this will give you actual measurement of 72 prism diopter. So this will induce significant error in the measurements when you hold the prism mistakenly. Okay. Long story short, typically we only use these or loose prism. We never use these unless you want to simulate things. And we don't use this loose prisms in trial frame unless you want to simulate something. But again, when you measure prism, always keep the back of the prism parallel to the frontal plane. Even if the eye is out, you keep going out without twisting your prism. Okay, and make sure that when you do that, the patient is actually looking through the prism. Because sometimes I see some of you just barely keep the apex bisecting the pupil, and the patient gets confused, and you get confused to see where the movement is. So try to make sure that the patient eye is centered within the prism itself before starting doing cover test. Okay. So we always hold our prisms in the frontal plane. Okay, we said frontal plane. Stacking prisms, we cannot stack 2 horizontal prisms or 2 vertical prisms together. So because let's say if you put 10 and 40, right, it is not 50, it is 100. Okay, and this is a complex concept of stacking here, because what happens is the interface is magnified here, so there's more bending happening more than the algebraic summation. And instead, you can do splitting of the prisms. So there is methods. This is a new type of prism bar that has like slides on them. You can stack horizontal and vertical prisms on them. But again, you cannot stack horizontal ones or vertical ones. You can split prisms instead. So we have very nice. I forgot to bring it with me. We have a loose prism set that comes with a small piece of magnet and comes with a metal ruler, so you can put the ruler on the face and you can put the prisms, and instead of holding 2 prisms in your hand and you get confused how can you control it, this will do the job for you. So this patient has large angle exotropia, around maybe 50 or 60. So we split 30 and 35 prisms, and you can see the impact on the Fleischberg test. Okay. So again, we split prisms. If you have big deviation that is beyond the capacity of your prism bar or your loose prisms, we split the prisms base in each eye, or base up in one eye, base down the other eye. right? But you cannot do two bays out or two bays in. You can put horizontal and vertical prisms simultaneously on one eye to check both horizontal and vertical deviation, but you cannot hold two horizontals or two verticals. Got it? When you check measurements when the patient in right head tilt or left head tilt, remember to twist your prisms as well. You don't keep the prism straight and you lose the head. Okay, so tilt the prism with the head tilt. Keep in mind the concept of primary and secondary deviation. So we spoke about that early on in those lectures. So this patient has right sixth nerve palsy, there is esotropia, and he is focusing with the left eye. Okay, but if we force the patient to fixate with the left eye, there will be significant innervation to the weakened right lateral rectus muscle to bring it in focus. And with a significant amount of innervation, there will be simultaneous innervation to the contralateral medial rectus muscle that will induce more esotropia than the primary esotropia. So the secondary deviation is always more than the primary deviation. That's why when you measure patients with strabismus, especially with restrictive strabismus or paralytic strabismus, you have to put the prism over the deviated eye. We are actually doing surgery tomorrow on a patient who had hypertrophy after buccal surgery. And it happens that her right eye is the dominant eye of her life, although she is like 20 in both eyes. But this is the dominant eye. When she developed the scarring and buckle that holds the eye significantly in hypertrophy position, whenever she tries to fixate with the right eye, there will be way more hypertrophy of the left. We are trying to blur her right eye by not wearing contact lens here, but she still, even with counterfinger vision, with uncorrected vision in the right eye, she still have tendency to try to fixate with this eye and induce significant hypertrophy on the contralateral eye. So again, find the paralytic or the phlegmatic eye, the restriction, and put the prism in front of this eye. Okay, Fresnel prism is a concept of trying to get the similar prismatic power of big prisms into series of small stacked prisms, and they are like very flexible. You can add them to glasses, and they are temporary. You can take them off at any time. One of the famous figures who get Fresnel prisms is Clinton when she had a concussion and sixth nerve paralysis at some point, and you can tell the base and direction of the prism from the prismatic effect of the temple here, right? So she seems to have like esotropia, and you can see the serration of the lens, and you can see the displacement of her temples through the glasses. And this is the way that you can tell the direction of the prismatic effect in any case. Okay. Other clinical application, prisms are present in almost every single instrument in ophthalmology, including ophthalmoscopes, slit lamps, making use of the concept of total internal reflections. We have poro prisms and dog prisms, whatever type that use in instrumentation. We start the story about speaking about prismatic effect of lenses, and we just get directed into the prisms itself. So think about lenses as if you are holding two prisms back to back. Okay, when you have biconvex lens, as if you're holding two prisms base to base, and when you have biconcave lens, as if you're holding prisms apex to apex. And this is important to understand the concept of prismatic effect. So because if you have an eye that looks through a thick plus lens, through the optical center of the lens, there will be no prismatic effect. The patient is ortho. Now this patient, for example, looking through the same lens, has esotropia. This is the right eye from above, okay? So this right eye is esotropic. Now, there will be, what type of prism effect here? Is it base in or base out? Base in. So the patient is looking nasally to the center, the thickest center of the lens, so there will be induced base in effect of the lens. Base out, sorry. Again, this is right eye from above, so this is the nose and this is the temple, right? So the patient has esotropia, the patient is looking away from the base, so it will be base out effect. Okay, which is a good thing, because when patient is esotropia, we correct esotropia with base out, right? Same when we have exotropia, the patient will be looking away from the center of the lens. Okay, so there will be base in effect of the thick plus lens, which is also a good thing, because when the patient is exotropic, we correct them and measure them with base in prism. Right? Let's see what happened to the minus lens. Well, before going there, the plus lens is good stuff because it will measure less strabismus. It will hide the strabismus by measuring less amount of strabismus, but it may make the strabismus look worse due to the magnification effect. So the eye becomes large and the deviation may be also magnified. So think about plus lenses as a positive person who always try to minimize, negatives in life. So we have plus measures less. Now, the opposite happens to the negative lens. So the patient is with biconcave lens, two prisms, apex to apex, looking through the optical center. There is no induced prismatic effect. If the patient has esotropia, they will be looking away from the center, away from the apex, and there will be base-in effect. Okay, and this is the opposite of the way that we measure or correct esotropia. We correct esotropia by holding prisms base out, right? But this patient is looking through base in. So the glasses here will give us false measurements that looks worse than actual. Okay? So it will be base in effect on esotropia and it will be base out effect in exotropia, which is again defeat the purpose because exotropia is measured and corrected by base in, not base out. Right? So again, the negative here is a negative person who looks at the negative things like empty part of the cup and make it worse. So we have the mnemonic minus measures more. So the patient with the strabismus who use thick minus lenses, we are going to measure more deviation than the patient actually has. But the magnification effect of the thick lenses will make the strabismus seem better to the viewers. Okay? In practical life, there are tables that can convert the actual strabismus measurement of what the patient has based on your numbers and the patient's refractive errors. So you can match the table and you can find how much. But again, the concept of minus measure more, M&M. Okay? So this is an example of a patient. It's not our patient. This is someone else, but you can tell there is high minus lens here and high plus lens here. So it can give impression of ophthalmos here or microphthalmia here. You just take the glasses off and the patient has normal eyesight. Okay? And you can also see exotropia in this eye. Okay? The light is like 30 prism diopters of exo. Right? But this is mistakenly high strabismus looked through the minus lens. But it always, with the magnification effect, the strabismus does not look like that bad. Okay, so let's go back to measuring the prismatic effect of these lenses. So we have the Apprentice Rule. This is different from the Apprentice position that we just mentioned. Apprentice Rule can measure the prismatic effect of a lens by multiplying the amount of decentration of the optical center multiplied by the lens power. But the decentration should be measured in centimeters. Okay? So let's say the patient has esotropia. They are looking at 2 millimeter nasal to the optical center, and the lens is only 2 diopter lens. Okay? So this is 0.2 millimeter times 2 diopter. This is very negligible, prismatic effect. But you can imagine things will go worse when you have high refractive errors. Okay, so this general rule that we can measure the whole prismatic effect of a lens by multiplying the power by 2.5. So let's say if you have a patient with exotropia of 40, okay, and they wear minus 10 diopter lenses on both eyes. So roughly we can tell that the prismatic effect of these lenses is equal to 2.5 times 10, which is the power of the glasses, equal to 25%. Yeah, 25% of the 40 prism diopter is 10 prism diopters. And we know the minus measure more, so we're going to add this to 40, so the patient's going to look like 50. So when you measure 50 with the thick glasses, you subtract 10, and this is the patient's, net prismatic deviation. On the other hand, if that same patient with XT of 40 is wearing plus 10, okay, the same concept, 2.5 times 10 equals 25%, and this is 10 diopters difference. But plus hides the strabismus, so we're going to subtract 10 from 40, so the actual XT that you can measure is 30. So if you have a patient with plus 10 glasses and you measure 30 prism diopters, automatically just add 10 more, and this will give you the patient's lower. Yes.
If the patient's wearing same prescription but in contact lenses,
Yes.
you don't need to correct, correct? Okay.
There's a difference. Yeah. So it also depends on the vertex distance, and there's no distance between the cornea and the contact lens at this point. We hope we can get Prism incorporated in contact lenses. This is going to be a great project, but I don't think it's available yet. Okay, so after this long journey, let's go back to our patients. Almost lecture's done. So we measured 20 prism diopter in the primary gaze. We measured 16 in the right gaze, and we measured ET of 12 in the left gaze. Remember the first impression? Okay, so let's analyze this. The patient is looking through -10 thick biconcave lens, right? So let's say the patient is looking 12 millimeter away from the center of the lens on the right gaze and 12 to the left. So the net distance is 24 millimeters multiplied by, so divided by 10 equal to 2.4 centimeters, okay? And then multiplied by the power of the lens, which is 10. So we have 24 prism diopters, prismatic effect only, induced by the patient looking from the right gaze to the left gaze. Okay? We measured actually from ET of 12 to XT of 16. So we measured 28 prism diopter difference between right gaze and left gaze. Okay? So you can confidently say that 24 of this 28 was prismatic effect. Right? So when the orthoptist came to David Guyton and told him that this is what's going on, Guyton just took up the glasses and see there's full movement and there's exotropy actually in the left gaze. That's esotropy. Okay? So what we saw was induced prismatic effect or reduced concomitant deviation due to prismatic effect of the thick minus lens. Okay, any questions? You guys have time? You have time for like 15, 20 more minutes? We'll let you go before 9. Okay, because there's interesting cases coming up, so I'll try to get through them quickly. Okay? Okay. Hold on.
Yeah, I'll take it.
Okay, so another case, we have an 11-year-old student bothered by recent reading difficulties with eye pain and double vision when he focuses. 20/20 vision, cover test was ortho at distance. There's a flick of exophoria at near point of convergence was about 12 centimeters. This is straightforward convergence insufficiency, right? So we can converge a flick of exophoria, orthotropy at distance. So we treat those. We came across this. I'm running because we discussed that before. So we do pencil push-ups. We do a block string to try to strengthen the convergence. But we have computer exercises as well. But if the patient looks for something less interrupting and to give constant training without the need for interruption from reading, we can give prism glasses. Which direction? Gaze out prisms, because we are willing to train the convergence. We want to induce convergence. That's right. So we give base out reading glasses to train their convergence, right? On the other hand, we have a young football player with multiple concussions, and he has significant double vision when he reads. He has to hold the phone far away or close his eyes. And this patient has 20/20 vision, but he has intermittent exotropy at distance and more manifest larger deviation at near. Okay, and his near point of convergence is way remote, like 35 centimeters. Normally it should be to the nose. No, this is 35. So you have very remote angle of near point of convergence, constant diplopia at near, manifest exotropy at near, and intermittent exotropy at distance. So this is, anyone knows what's the type of strabismus is that? So it's obviously convergence insufficiency, right? Because there is more deviation at near than distance. But this is convergence insufficiency type exotropia. This is different from the previous diagnosis of convergence insufficiency alone, because it was not exotropia. The patient was ortho at distance and flick exophoria at near. But this patient has actual exotropia at distance and near. So this is convergence insufficiency type exotropia. Okay? So this patient is old enough with multiple concussion. There is weakness in the mechanism of convergence centrally in the brain. and there is no, he's heading to presbyopia age, and there is no way that we can train his convergence. So we need to alleviate his or her symptoms. So we're going to prescribe Prism glasses. What direction is the Prism going to be? It's in. Perfect. So because we gave up with convergence, we need to alleviate symptoms at this point. So we're going to divert the image toward the apex, toward the patient deviation, and do base M reading glasses. Okay? So we have a lady who is unhappy with her progressive glasses. She always sees double when she reads only. Okay? So her vision is great, 25. She sees great at near as well. And this is her refraction. +4 on the right eye, +1 on the left eye. Very mild cataract, and there is no significant, strabismus. But she is unhappy with the double vision. What do you think? And why it is reading only? Okay.
Converges a bit for reading than the plus ones at the ad.
There's a prismatic effect induced when she looks down, induced by her anisometropia. Okay. So this is the patient looking through the optical center of distant refraction. And this is her reflectors. Okay. But when she looks down, the story will be different. So if you want to count the spherical equivalence of adding half of the 1 to the 4, we have 450 here, and here we have 125 spherical equivalent. We have at least 325 anisometropia. Okay, so when the patient looks down in this gaze, it is a plus lens, so it is as if you are stacking prisms base to base. So imagine the central line here is the base of the two prisms, and when she looks down, there will be base up prismatic effect. And when we assume that the patient looks like a centimeter below the optical center when she looks down, okay, she will have net prismatic effect of 4.5 diopters multiplied by 1 centimeter equal to 4.5 base up prism induced when she looks down in the right eye, whereas in the left eye we have only 125 prismatic effect base up. So the difference between the two is 3.25 base up prism favoring the right eye because it has more prismatic effect. So the patient is as if looking through base up prism. Double vision. Clear? Okay. So how can we fix that? This is an interesting concept that's only applied in this situation called slab of prisms, in which the optician can grind the lens, the bottom segment of the lens, okay, to eliminate the prismatic effect of the lower segment of the glasses. So there is slab off and there is reverse slab off. Slab off, there is very specific terms applied here. So slab off will induce base up prism and is only applied to the back of the lens, and we use it for the weaker lens. Okay, so the one we have less plus or more minus. Okay, and on the back surface of the lens. On the other hand, we have the reversed slab of prisms in which we add face down effect on the front surface of the lens, on the lower segment of the lens, and on the stronger lens, the more plus or the less minus. Okay. I always get confused, so I try to create mnemonics fancy. Slab off, and slab up, so it's base up prism. Okay, right, with the effect. So in this patient, the prismatic effect is the 325 base up over the right eye. So this one has the more plus and has the base up prism. So we're going to fix this. We're going to use, if we're going to use slab off prism, this is a base up prism induced on the weaker lens, right? So we can add slab off prism base up over the left eye to neutralize the prismatic effect on the right eye. Or we can use reverse slab off prism over the right eye to induce base down to neutralize the base up effect. Clear?
Is there anyone that's like preferred or is tolerated better or?
I think the slab off is easier, but both concepts are more expensive, I think. So again, there's very limited use. It's only for new segment of the glasses. It's only for a certain amount of deviation, and you can understand there's going to be an issue when you are creating a lot of anisometropes by monovision cataract surgeries, right? So you may have patients who are perfectly ortho, and then when you want to put them back in the glasses and they have induced anisometropia with monovision glasses, you may face this problem. So try to be more conservative with this, amount of anisometropy. So it's like one diopter will be okay, 1.5, but with that amount 3, it's beyond huge amplitude of the patients. Okay, so we just talk about how to subtract prisms. So this will lead us to the topic of prismatic summation, how we add the prismatic power. So when you have horizontal prisms, if they are in the same direction, we do algebraic summation. So we have 8 bays out, 8 bays out, the equal is 16 bays out prism, right? If you have 4 bays in, 4 bays in, this is 8 bays in effect, okay? At the vertical deviation, we do algebraic summation for the opposite direction. So we have 4 bays down, OD, and 4 bays up, OS. This is 8 total vertical effect, okay? And you have 3 bays up, OD, and 2 bays down, OS. This is 5, okay? So vertically, you just add when they are in the opposite direction. Horizontally, we just add when they are in the same direction, both bays out or both bays in, okay? Now, this is a patient with nystagmus, and he starts reading the chart with this significant left face turn, okay? So mom asked if surgery can help with this head posture. So we can test that by applying yoke prisms. And yoke prisms, basically, our prisms are held in the same orientation, not in the same direction. That makes sense. So opposite direction, same orientation. So there is no summation here. So if you hold 40 prism diopter bays out in the right eye and 40 prism diopter bays in the left eye, the net power is still 40. There will be no summation here. Okay, so 40 bays in OD and 40 bays out OS. The net power will be still 40, but bays left toward the base. Okay, and this aims to move the null point to the apex. Okay, so this patient has nystagmus, right? And we saw that null point is in his left gaze. In his right gaze, sorry. So he's turning the head to the left to keep the null point in the right gaze. So to mimic the situation after surgery, we hold yoke prisms, bays out OS, bays in OD. And the net power will be 40 prism diopter bays left. Okay? On the other hand, we want to move the null point in his right gaze to the primary gaze. So you can hold the prism bays out OD and bays in OS. So the net power will be 40 prism diopter bays right. So the image will shift toward the apex. Okay? So the null point will go to the apex. And that will create an interesting rule for you to memorize. Apex goes to the null point as Dr. An. Okay? An's rule. Vertical prism, we do the same direction with no summation. So 10 bays down, 10 bays down, equal to 10 bays down. Okay, 10 bays up, totally bays up. So when you have a patient with chin up posture, and we want to move the null point to the primary gaze, we hold like 20 prism diopter bays down, and we are moving the null point to the primary gaze, to the apex, because the apex are pointed upward. So the net power will be 20, not 40. Okay. And we have some trial of loose prism, but they are a Fresnel prism because you can imagine when you hold 40 or 50, it can be very thick. It's confusing. But this is like a trial lens with built-in Fresnel prism that you can, try it in the clinic in certain situations. But if we have yoke prism, but they are unequal, then we're going to subtract. So if you have 40 prism diopter bays in over the right eye and 40 prism bays out of the left eye, the net power will be 30 prism diopter, favoring the left direction. vertical prism in the same direction, we do subtraction. So 10 base up and 4 base up OS, the net power will be 10 base up, 6 base up. Sorry. Applications of using York prisms can be used in hemolymous myopia. If you have hemispatial neglect, nystagmus with abnormal head posture, as we saw, that you can simulate or you can even treat the head posture. I have a patient with dorsal midbrain syndrome, and she has convergence retraction nystagmus whenever she looks straight. So she always lived with this 45 degrees of chin up posture. So when I put her in 40 base up prism, she was so happy to relax her neck. But you cannot give prism glasses like this. So I gave her a fellow prism trial. She liked it in the way that alleviated her neck pain, but the vision quality was bad. So we ended up with doing surgery. We did a large anterior recession and speculous resection. So we're going to move the null point primary image back to normal. Okay. I remember a very interesting case of PSP. It's the only case I see my wife in neuro-ophthalmology fellowship. A patient who claims that he cannot read despite he has perfect vision, and in fact he cannot look down. And I remember we tested him in the clinic by holding a plate of blueberries or something that he had to put like stack books to keep the plate in the level that he can see. He cannot look down at all. And then funny in Amazon, I found this funny prism glasses that you can basically divert your sight, so you can read without moving your neck. So it's something that can be helped, with this patient. Now, I was testing him. Interestingly, this patient had null point also in convergence. When he converges, the nystagmus stops, and mom complained that he always holds stuff very close to his face. So I wanted to simulate convergence, not York prisms only. So I put 7 base out prism OU, and also over minus him with -1 both eyes, so he can accommodate and he can converge. And while he's reading, he was immediately straight ahead while he's looking at the distance. Okay. I think. Yeah, we'll go quickly through this. There's a lady with sensory exotropia, bright eye due to history of congenital cataracts with multiple surgeries. She's looking for cosmetic solution and trying to avoid surgery. She has exotropia of 25% diopter and no vision in the right eye, no significant vision, hand motion vision only. Azim knows this because we had a case a couple of days ago. Okay, so we want to hide the prism from the viewer to improve her self-esteem without doing surgery. We are not correcting exotropia here. We are correcting the appearance of her exotropia. So I want to deceive the viewers when they talk to her and to see less exodeviation by holding the prism in the opposite direction of treatment. So I'm not treating exotropia with base in the prism. I want the viewers to see the eye moving toward the apex of the prism. So I'm going to hold the prism base out, right? So the apex will be toward the nose. So when the viewers look at her eye, they will see the eye going inward, not outward. Makes sense? So this is cosmetic prism. It does not meant to treat diplopia or to correct strabismus. It's meant to reduce the appearance of the strabismus to the viewers by holding the prism in the opposite treatment position, apex toward the nose. Okay. So if you have exotropia, you will hold the base out. If you have exotropia, hold the base in to move the eye out of the base. It is not that effective because with you only get like 1 millimeter apparent correction of the position of the eye per 8 prism diopters. And remember we mentioned that each millimeter equals to around 7 prism diopters, right? This one we did the Hirschberg test. So this is the amount of what you get. So basically, you may use some thickening in the glasses, but can help with hiding, the strabismus. It works great if you have a patient with microphthalmia, like with PFV and have microphthalmic eye. So if you add more plus with decentration, you're going to have the magnification effect that will make the eye look bigger, and also the prismatic effect that will hide part of the strabismus.
Wait, was it 1 millimeter every 15 or 1 millimeter for every?
Yeah, 1 millimeter for 15. Yeah, you're right. This is a different concept. Yeah, sorry. Yeah. A frequent question that we get asked in practice: because I have prism in my glasses. And a quick, easy answer to do is to hold the patient's glasses across the table and see if you can see displacement of the edge, whether table, Kleenex, whatever, flat surface. And to understand, to eliminate exactly the difference between a ground prism glass that has prism throughout the whole lens, or prismatic effect of thick glass, when you have prismatic effect on the corners of the eye. So I do not have prism in my glasses, but if you can check at the border, some sense, you can see the edges displaced here, because this is based out prism effect. But if I go in the optical center, you can see the line is continuous, right? But if you go this way, you have base and prismatic effect. Okay? Yes, over glasses here. Okay. Yeah, this is the optical center. But if I go to the edge, you can see displacement. Out.
You should be.
Yeah. You can see the match. So basically, the optical center is continuous. If you go to the edge, you can see the phase out. This is like space.
Yeah.
And phase in. It's because of the eye contact.
Yeah.
One more check here. So in the center we have a straight line.
Exactly.
Right.
But at the center, that's center.
If I go to the edge, you can see there's a phase out prismatic. The line is spaced slightly. There's slightly base in. But there's a sweet spot on the line. Prism glasses, you do not see this sweet spot. If you move the glasses across the edge, you're going to still see this movement. And in order to measure precisely the amount of prismatic effect when the patient is using the glasses, put a quick, like a small tape or marking pen at the optical center. So put the glasses on and mark the pupil on the lens, and then hold the lens over the table and see how much prismatic effect I can have, and to say how much you can hold the prism in the opposite direction. So this patient has which direction? So this is the left eye. This is the nasal bridge. Okay. So which prismatic direction do we have here? Base end, because the image is shifted to the temple. So you neutralize it by holding prism base out. So I hold two prism diopter and see if I can get the line continuously straight. If not, I add mic 4 or so. So you hold it by the opposite direction. Or you can use the lensometer. Lensometer has a dial I can show you that will measure the prismatic effect. So typically the intersection should be in the middle, right? But when you have prismatic effect in the lens, you're going to see this intersection point goes up, and each circle represents specific prism power based on the type of the lensometer. So it starts with half, 1, 2, 3, 4. But the cool thing is lensometer, you don't have to do this math conversion here. Wherever you see the displacement, this is the base of your prism. So if this is the case, this patient has base up prism. You don't have to make the math. So displacement goes to the base. Okay. So let's recap. It was a long talk. Hope you didn't lose attention and get distracted. Just summarizing one slide. So think about prism that the light always goes to the base, and the virtual image goes to the apex, right? And measure strabismus by pointing the apex toward the deviated eye. Use the frontal position when you use the prisms, parallel to the frontal plane of the patient. Split prisms between both eyes, but never stack prisms in the same direction. You can stack horizontal and vertical, but not too horizontal, not too vertical. Prismatic effect of the lens, we use Apprentice Rule, in which the prismatic effect equals to the amount of decentration in centimeters multiplied by the power of the lens. Minus lenses always make things worse. Minus measure more, but it hides the strabismus partially by the magnification effect. Slab of prisms for the bifocals and anisotropes. Think about York prisms, Victor Hahn's rule. Apex goes to the null point. All right, so Dr. Gatton is the amazing guy I worked with, and he used to have this in-person optics courses that he goes to many residency programs and give comprehensive courses. One of his students, who was his fellow for a while, David Hunter, has he carried this mission of optics training, and he has a YouTube channel that he has annual updates. Alex Christoph was the orthotist I worked with during my training, and Cindy was the one who presented the first case, but I get the presentation from her and add my animations and all my fancy touches. I feel there is some deficiency in your overall optics training. I think the BCSC textbook in optics is so redundant and so dry, and there is no structured optics curriculum, I think, in your training. I remember in Hopkins, we used to have dedicated ground rounds in optics. So we have weekly ground rounds, and they are like rotated in different topics. So when you know what case you're going to describe, because it's already in the schedule that we have maybe 2 or 3 optics ground rounds in a year. We go over interesting cases about optics. This textbooks I read during my residency training in Jordan, and this is one of the famous, very simple, well-illustrated textbooks that is helpful in all international degrees like FRCS and FRC Opt and the International Council of Ophthalmology, IC Opt. Salman Sarwar, I think, purchased this book, and he read it, he liked it. I borrowed the book from him sometimes for preparing this lecture. So this is the barcode for Amazon, buy the book. Another resource I mentioned, David Hunter. So he has this YouTube channel. Again, he has this like 6 hours YouTube video that he goes into all concept of refraction, from basic simples of Snellen refraction all the way to the complex, things that you may encounter in your real life and in LCAP exams. So this is the link to the video that he has. And thank you all. All right, there's a long presentation. I hope you lose attention and focus here, but I think it covers important practical application of Prisms. So that will be it before we head up to VCU. Any questions?
Thank you.
You're welcome. Wish you all the best, guys. Sorry, I was hoping to get one more journal club before I leave, but